How many people are attending?
I think Sudhir will know.
166 people. You can see at the top.
Ah, okay. Yeah, I'm not used to using Zoom. I just started that a while ago because our data protection in our hospital hates these platforms, and I only use it privately on certain occasions. So, welcome everybody. First of all, I have to excuse myself. I'm late because I thought this presentation is going to be tomorrow. This is why I'm a little bit unprepared, but I will do my best to improvise and still tell you what I found out about the antiphospholipid antibody syndrome.
Yeah.
You want me to introduce myself as a person?
I just introduce you, Peter, very briefly. Everyone knows you in India, so you don't need any introduction, and you're a great guy and a great friend. So I think, you're the director of clinical neurology at and co-chief physician clinic for geriatrics, member of the executive board of ESO, founding member of German Stroke, and he's a great speaker. He's powerful, candid speaker, and we love to listen to him. So I think that's what you are. Please go ahead, Peter.
Okay, so I choose a topic that I came up to recently because of some patients we had, and looked back into it, and I was amazed at how many experts there are about the antiphospholipid antibody syndrome, but nobody, excuse my foul language, knows shit about it. So especially in context with stroke, so arterial thromboembolism to the brain, as you all know, there is scarce literature, and the literature that I found is pretty old. And people who are my age or older may remember these trials, but colleagues who are younger may not. So I'm going to talk about the antiphospholipid antibody syndrome, shortly APS, in the context of stroke. Now, what is it? It is a systematic autoimmune disease characterized by the following, alone or in combination, which is arterial thromboembolism, venous thromboembolism, microvascular thrombosis, and pregnancy complications, which are typical and belong to the diagnostic criteria, including multiple spontaneous aborts that have no other explanation. It is characterized by persisting antibodies, and there are 3 of them: anti-cardiolipin antibodies, anti-beta-2 glycoprotein 1 antibodies, and lupus anticoagulant. There is a prevalence of 40 to 50 among 100,000, and it, depending on publications, in up to 10, maybe even 15%, is the cause for multiple aborts. It can be a primary disease, or it can be associated with other autoimmune diseases, typically systemic lupus erythematosus in up to 30%. So as a background, the thrombosis risk is elevated with the presence of either lupus anticoagulant or anti-beta-2 glycoprotein 1 antibodies. And they have a higher risk than anti-cardiolipin antibodies alone. And important is whether you have high or low antibody titers, especially for IgG, more important than IgM. And the more positive antibodies with high titers you have, the higher your risk for any of the 4 complications: arterial, venous, microthrombotic, or multiple aborts complications there is. So if you add on that additional risk factors for venous or arterial thrombosis, including pregnancy, of course, such as smoking, hypertension, diabetes, hyperlipidemia, that risk further increases. Antiphospholipid syndrome is found in some series in up to 10% of patients with a TIA or an ischemic stroke under 50 years, although I personally think that is overrated. And if you have a true antiphospholipid antibody syndrome, the recurrence rate may be as high as 5 to 12% per year under antithrombotic effective therapy. It's also associated with cognitive impairment, even without TIAs and ischemic stroke, and with morbus Moschkowitz, thrombotic thrombocytopenic purpura, and catastrophic antiphospholipid syndrome, which has up to 50% case fatality rate. This is a graph that shares a little bit of the pathogenesis. And as you can see from left to right, B cells produce antiphospholipid antibodies against beta-2 glycoprotein 1. These antibodies bind to and lead to activation of vascular endothelium, and also other inflammatory cells enter the stage, such as platelets, neutrophils, complement, and so on. Subsequently, a prothrombotic state exists via multiple proposed mechanisms, which also, for instance, and not alone, but include reduced protein C, tissue factor inhibitor activity, as well as increased vascular tone. And then maybe there is a second hit, such as smoking, pregnancy, malignancy, or others, leading to the clinical syndrome with vascular thrombosis, other complications, for instance, renal dysfunction, and pregnancy complications. The diagnostic criteria are not clearly defined, and different opinion papers have varying definitions, but the common ground, more or less, is that you have clinical symptoms, otherwise unexplained, excuse me, venous or arterial thrombosis, unexplained PTT prolongation, which is caused by lupus anticoagulant, a known autoimmune disease, especially SLE, and you need to exclude malignancy. As you know, Trousseau syndrome is a disease where, based on a malignancy, you have a prothrombotic state, which typically causes multiple embolic strokes in multiple vascular territories. You need to exclude malignancy. You have to check for heparin-induced thrombosis and thrombocytopenia and other reasons of thrombophilia. And the very important and critical thing is that you need to have antibodies, and the antibody test has to be a positive result at least twice, more than 12 weeks apart. And you need to look because transient elevations are reported in infections, and they are usually mild and not high titers. In malignancy, and also with certain medications. So if you have low titers of non-persisting single antibodies, that doesn't mean that you have an antiphospholipid antibody syndrome. You can see that with increasing age, like low titers of 1 or 2 of those antibodies, and up to 12% of the population that then ultimately doesn't have antiphospholipid antibody syndrome. So there is a high risk of false positive diagnosis. These are taken from the very recent paper of Metzoff and colleagues, revised classification criteria for antiphospholipid syndrome. I understand that this presentation is going to be available as PDF and video. There's also a video taken, so I'm not going to read that out in detail. You can refer to this slide and the revised classification criteria, or to the original publication in MGA in 2019. These are the laboratory criteria which I want to address, because this is the most often or the most frequent reason for false positive diagnosis of antiphospholipid antibody syndrome. You need to have it present, the anticoagulant and the other factors, on 2 or more occasions at least 12 weeks apart. And you need IgG and or IgM isotype in serum or plasma in medium or better high titer levels. And you should have anti-beta-2 glycoprotein antibody also on 2 or more occasions at least 12 weeks apart, larger than the 99th percentile. So what they want you to see is high titers. Pitfalls. Lupus anticoagulant tests can be false positive in patients who are on NOACs, all of them, or on vitamin K antagonists. 5 half-lives pause of oral anticoagulation is necessary to obtain valid test results. You can bridge with low molecular weight heparin, although this is obsolete in general in stroke patients or others, referring to the bridge trial, which has been published a couple of years ago in the New England Journal of Medicine, showing higher risks of infarcts and bleedings if you bridge patients on VKAs. If a patient is on treatment, it's really difficult to get a valid test. There are special absorbers for NOACs, which can be added to the blood sample, but you need a highly specialized laboratory, a high quality laboratory that actually does that. And you yourself need to know what you tell them to do when you submit a blood sample for them to be analyzed. Vice versa, INR measurements may be invalid in patients who have lupus anticoagulant. There is a rationale for comparative studies of NOACs versus VKA, which I'm going to present to you later. There are other manifestations, clinical manifestations of the antiphospholipid syndrome, which are important for you to know, which are thrombocytopenia and hemolytic anemia, also neurological, as I mentioned before, unrelated to stroke, cognitive dysfunction. And nobody really knows what that is. It might be microthrombotic. It's associated with white matter lesions on imaging, as in subcortical arteriosclerotic encephalopathy, cardiac valvular lesions, coronary artery disease, MI, renal complications such as thrombotic microangiopathy and glomerular disease, and cutaneous complications like even a necrosis and ulceration. This shows you if you have something of that complex, the clinical syndrome of arterial and or venous and or microthrombotic complications, no other explanation. This is a multi-specialist problem and disease. And you need to be aware of the symptoms, and you need to be aware that you need to consult on cardiology, nephrology, dermatology, hematology, and work together to solve that problem, and especially solve the problems associated with antibody testing. So what do? You have primary and secondary prevention. There are some treatments coming also from SLE, like hydroxychloroquine and statins. There's antithrombotic therapy alone or in combination, including aspirin, VKAs, NOACs, low molecular weight heparin. And there's immunomodulation, going from cortisone to plasma exchange to IVIC and to reserve treatments such as rituximab and eculizumab. The later one, if you know it from, you may know it from myasthenia gravis, is working against the complement cascade. So if you go back into the literature in terms of therapy and stroke, as I said before, some of the older ones among us may remember the WARS trial, WARSS, the warfarin aspirin on the prevention of recurrent ischemic stroke trial headed by J.P. Moore. And if you read the names here, some of those guys were young residents, as for instance, Greg Albers, or senior residents, or maybe house officers. Now they are middle-aged stroke experts of a worldwide renown. And you can see that this paper is quite old. It's the WARS study, and integrated into the WARS study is the APASS study. If you remember WARS, that was a comparison warfarin aspirin, and it found out a non-cardioembolic stroke that over a 2-year period, there was no difference in the secondary prevention effect between aspirin and warfarin. So both options at that time were regarded to be a reasonable therapeutic alternative. As we know 20 years later now, warfarin in these patients is not an alternative. These are the curves, and you see the probability of an event in WARS. This illustrates the conclusion that I showed you before. Now, APASS is the antiphospholipid antibodies and subsequent thrombo-occlusive events in patients with ischemic stroke study. You need to understand that this trial, as it was nested in between, was not randomized. So patients were not randomized for their antibody status or for antiphospholipid anti-syndrome, but it's a prospective cohort study within the WARS trial. You were judged to be APL positive if you either had anti-cardiolipin antibodies or lupus anticoagulant or both. There was no testing for anti-beta-glycoprotein 1 antibodies. And in this trial, 41% of the patients within WAS that were going into the APASS trial, which was a big majority, 1,954. At the end, it was 1,770 patients in APASS primary analysis. Nearly half of them were APL positive. And that already tells you that there must be an extremely high rate of false positives that have been included into this prospective nested cohort study. The INR in the WAS trial was 1.4, which is far too low, as we know, to 2.8 versus aspirin. And what they did, and I cannot, this is better. I can show you the results here. As you can see, comparison between APL positive and APL negative. You see, looking at the p-values, that there were no big differences except of the presence of female stroke patients. Whites versus non-whites was a difference in APL positives. There were more women and more whites in APL positive patients, and a history of smoking, excuse me, the other way around. And smoking was higher in patients that were tested APL positive. And if you look at the primary endpoint, you can see that there was virtually no difference in between the 720 patients APL positive versus APL negative for death from any cause, for recurrent ischemic stroke, 0.6% absolute, for TIA, which was more frequent in patients who were APL negative, for MI, for pulmonary embolism, deep vein thrombosis, no differences at all. And if you try to split that further up, and I'm not going to try to go into details, you can see overall patients who had 2 positive antibodies at least had a trend for an increased adjusted odds ratio for getting a primary event. This was just barely missing statistical significance, but was a hint. For warfarin alone and aspirin alone, even adjusted, there was no statistical significance. But if you look at the curves, the Kaplan-Meier curves by APL status, you see that APL positive patients appeared to be a little bit better, non-significantly, on warfarin than APL negative patients, and the aspirin patients were inconclusive. The lines cross here in the middle. So in conclusion, the presence of either lupus anticoagulant or anticardiolipin antibodies among patients with ischemic stroke did not predict increased risk for subsequent vascular occlusive events over 2 years, and neither predicted a differential response to aspirin or warfarin. So they concluded that routine screening for APL in patients with ischemic stroke does not appear warranted because it will not have any therapeutic implication. Unfortunately, if you look again at the numbers, most internists, nobody discusses this trial. This trial was lost in the literature. I even had to dig very deeply to find it. Most general internal medicine journals don't even know these studies, WARS and APASS. But if you look how these patients were tested, you see that APL positivity was seen in 6.7% positively tested for both. And high positive antibody titers were seen in a minority of those. So in this trial, there was a very, very, very small number of patients who at the end, looking at it from today's perspective, had a true antiphospholipid antibody syndrome in this trial. So I think comparing then warfarin therapy with an INR of less than 2.0 in this trial, this is not useful for us, leading me to the conclusion that we don't have a designated stroke neuro trial for antiphospholipid antibody syndrome and the kind of antithrombotic therapy we should choose. We don't know anything about aspirin, clopidogrel, the combination of both, maybe even Brilic or other GP2B3A inhibitors. We don't know anything about warfarin. We don't know anything about vitamin K antagonists. So there is a whole lot of room for improvement and for new trials to be done. Now, what we know something about is the comparison of warfarin and new or non-vitamin K oral anticoagulants. And the one that has been tested most extensively is rivaroxaban. And this is the TRUPS trial, which is much newer than what I presented you before, but it has nothing to do with stroke. It just gives you an idea which drugs you should probably avoid. It was published by Pengo and colleagues in Blood. And sorry about that. It was the first direct comparison of NOACs versus vitamin K antagonists, randomized multicentric non-inferiority, probe design, open inclusion but blinded endpoint, rivaroxaban standard dose versus VKA INR 2 to 3. High-risk patients with thrombotic APS and triple positive antibodies as defined in the new diagnostic criteria. And what you can see in the TRUPS trial, events as treated, 19% ischemic strokes and myocardial infarctions in the rivaroxaban group versus 3% in the VKA group. The hazard ratio is nearly 7. This is significant. And the TRUPS trial was stopped by the DSMB because of event rates and hazards. Bleedings also were twice as high in the rivaroxaban group compared to the ischemic stroke group, to the VKA group. The p-value here was non-significant. Now, if you look at this table, you can see the numbers again, 19% in the rivaroxaban group versus 3% hazard ratio in the ITT analysis, a highly significant value for an excessive risk of thrombotic events. And also, if you look at the bleeding rates, non-significantly, they are numerically higher in the NOAC arm. In the aftermath, at least in Europe, the European Medical Agency changed its phrasing and put out a warning for patients with antiphospholipid antibody syndrome. And it reads, NOACs, including rivaroxaban, apixaban, edoxaban, and dabigatran, are not recommended for patients with a history of thrombosis diagnosed with APS. In particular, for patients that were triple positive for all 3 antibodies, treatment with NOACs could be associated with increased rates of recurrent thrombotic events, so you shouldn't do it. There's another patient-level meta-analysis coming up with the same result. The majority of patients treated with the rivaroxaban and dabigatran, triple positive patients with a previous event, had a significant 4-fold increased risk for any endpoint on a NOAC. 16% recurrent events within 1 year. The normal risk is about 5 to a maximum of 10 to 12% per year. So NOACs are not effective when indirectly compared to warfarin. This is a final study also showing twice as high rate for recurrent events in rivaroxaban versus VKA. This is a third analysis, a randomized non-inferiority trial, increased risk of thrombosis for recurrent thrombosis, venous thrombosis with rivaroxaban in patients who had a previous arterial thromboembolism, a dermatological condition, or APS-associated valvular disease. I'm gonna skip this, but for stroke, in rivaroxaban group, there was a 10% risk compared to 0% in the warfarin arm. These are the graphs, recent article published in October 2019. So you can get the impression there's one thing that you do not want to do. You don't want to use NOACs when you have a patient with APS. And if you use NOACs, you might head into issues. And the best data for not using a NOAC come from rivaroxaban. I'm not saying that rivaroxaban is the worst of all NOACs, but I'm saying that the most data we have for NOACs in APS are rivaroxaban data. And I think the European recommendation to avoid all NOACs in patients with antiphospholipid syndrome stands and is good. These are subgroups. You cannot see anything out of these subgroups that will help you to derive another idea, to get to another decision in terms of NOACs. NOACs should not be used. Nevertheless, what you can see in this paper here are the therapeutic recommendations, and thromboprophylaxis in SLE with antiphospholipid antibody syndrome, there's a strong recommendation with moderate evidence to use hydroxychloroquine and aspirin. And for copyright reasons, you can look at it because I quoted the paper I have taken it from, but you can look at the original paper, which is quite good, in fact. Here you can see low-dose aspirin, weak recommendation, warfarin. I don't know why this presentation jumps, I'm sorry about that. Warfarin with a strong recommendation, target INR 2 to 3. Warfarin more than 3 is not graded. Combination of warfarin and single antiplatelet. There is a strong recommendation with moderate quality evidence if you have a high risk setting with 3 positive antibodies and arterial thrombosis. You could switch to LMWH, low molecular weight heparin, if you had a recurrent venous thrombosis on anticoagulation. And all of these are not so interesting to us. If you run into a catastrophic APS, everything is allowed. High-dose steroids, plasma exchange, immunoglobulins. I personally have never seen that. And you should not use direct oral anticoagulants. You may use rituximab or eculizumab in life-threatening resistant APS as a salvage therapy. This is very complicated and extremely expensive. There is another table from a German group published in Vasa. It says that moderate APS or mild APS, you could use DOACs. I never understood why they say that. Aspirin is not required. In addition, I would use VKA. I'm just going to show that to you to illustrate that there are different opinions. I would be very, very careful. And who tells you that a mild APS with a single antibody positivity is not a double or triple positive APS in the years or months to come? So if there is an indication for anticoagulation, I use vitamin K antagonists only at the current time point. And finally, I want to share a note. I know that you also live in COVID times in India. And there are some interesting cases. There's interesting pathology in COVID-19 disease. And the pathology is microthrombotic. And lungs that have been analyzed in pathology have a lot of microthrombotic complications. Patients experience strokes, even if they are younger and have no other risk factors. And nobody really knows whether that is caused by inflammatory markers, inflammation, or sepsis itself, or whether there are other factors that may play a role, vasculitis, autoimmune antibodies, such as antiphospholipid antibodies. And in fact, if you have patients with stroke that are COVID-19 diseased, active COVID-19 disease, you should also check for antiphospholipid antibodies to prevent further strokes and peripheral arterial or venous thrombotic complications. I think there is something to it. It's only case reports at this point, but COVID-19 is a very interesting disease, as you all know. So, in summary, work up if a clear indication is given in a specialized laboratory. That's a take-home message. It's indispensable for adequate risk stratification. You need to know the antibodies and the titers, and you need to know that qualitatively well. Many patients with a suspected APS may not have one, and such patients are low-risk groups for recurrent venous thromboembolism and well treated with NOACs, because you can give it to them because they don't have an APS. Patients with 1 to 2-fold antiphospholipid antibodies without lupus anticoagulant have a comparably low risk for thrombosis. You might consider NOACs. I would prefer VKA. And with a high-risk APS, triple positive antibodies and or arterial thromboembolism should get no NOACs but vitamin K antagonists, INR target range 2 to 3, and it's unclear whether additional aspirin helps, but if you have a second recurrence or a very strong arterial risk profile, and especially a second recurrence under effective oral anticoagulation with a INR and target range, then I would do a double treatment with VKA and aspirin, low dose 100 milligrams. My advice with APS and first ever stroke stands, it's VKA, and add aspirin if it's recurrent, and consider further immunotherapies if you have recurrent arterial vascular events under an optimal antithrombotic therapy. Thank you very much, and I'm happy to take questions.
Yeah, thank you so much.
Yeah, thanks, Peter. I think it was a nice talk. So I think we've lost some time. So I guess we'll the questions are coming up to you directly on your laptop. So would you like to answer them, Peter?
I think Dr. Chengappa can take some of the questions. Is it okay?
I cannot see.
If Dr. Chengappa can ask some of the questions.
So
yeah, sure.
And even Dr. Hastak, sir.
I have to get back on my screen. I don't.
Okay, Peter. Meanwhile, we could start off. You have a patient. Dr. Chengappa, go ahead, please.
Sorry.
Ask the question.
One of the common questions that have been coming up is when do you investigate for antiphospholipid in a case of stroke?
In a case of stroke, if I don't have any other explanation and I'm looking for coagulopathies. So a patient under 60, juvenile stroke mechanism, maybe a weird history of aborts in the past, maybe a vasculitic history, maybe even an autoimmune disease such as SLE or others, I always check for APS. But what I do in those patients, I do exactly what I said before. I check for APS twice within 12 weeks. I also add a distinct vasculitis laboratory to that. And we always also do factor V Leiden testing and prothrombin mutation testing with that. We call that our coagulopathy panel in the young stroke patient.
Peter, would the pattern of infarct seen on MRI, and of course the angionegativity, would that also help for you to decide is this APS or not? Does the pattern on MRI help in any way?
No, it wouldn't, in my opinion. There are no data about that. It's just a gut-based opinion. I personally think that what makes me nervous is embolic strokes in multiple territories. I do a very close cardiac follow-up and checkup. I do an oncologic checkup because this can be caused by occult malignancy. And in these patients also I do our coagulopathy panel. But I try to take a good history. And if there is no specific history, I do not do the testing because it will come out negative in most of the cases.
All right. So the other question is, you have a patient with an antiphospholipid antibody syndrome, an arterial stroke. I mean, is it true that in the venous strokes there is better evidence for warfarin as compared to the arterial strokes, but you still use warfarin in arterial? But if you have, go ahead.
I use warfarin primarily because arterial stroke is one of the high risk profile diseases. So I do not use warfarin if the patient comes back with a low titer lupus anticoagulant and the other antibodies are negative. Then I don't think that the stroke is associated with an APS. Maybe the patient doesn't even have an APS. But if I have triple positivity and an arterial stroke, and 2 or more of these are high titer, I primarily give warfarin. Because these patients also, I mean, they can have lice and fleas and other diseases. They can get venous and arterial and microthrombotic strokes, but also heart attacks, but also limb ischemia. They can get bowel ischemia, they can get renal ischemia, they get pulmonary embolism. They get all of this bullshit. And I just feel better with warfarin for all parts of the body, not only the brain.
So if you have a patient who has an arterial stroke and has thrombocytopenia in association, 60,000 count or something like that, or, what would you do then? Would you still use warfarin?
Well, thrombocytopenia depends on, I mean, I would have to look for other reasons. Why, is there a TPP? Is there an ITP? TTP or ITP, other reasons. But a thrombocytopenia below 30,000 would need hematological checkup. Even then, I would treat with a VKA.
Right.
If the APS is established, as I showed you before.
Right. And of course, if it's an SLE or a secondary antiphospholipid antibody, how frequently do you see strokes in them? I mean, is that a common feature in SLE as well?
I asked myself when I prepared that talk, what actually is definitely a secondary APS? Is an SLE with an APS a secondary APS, or is it just an APS that belongs to the disease SLE? So I would rather call it something like idiopathic APS versus APS, defined as by the vascular complications and or aborts and proof of 2 or 3 high titer antibodies. So if I have an APS and another disease going with it, I would call it secondary, and it doesn't make a difference to me because the current pathophysiological reasoning is that the antibodies are causative and have an additive risk. I would rather treat the risky condition, and I would not make a difference in between primary idiopathic or secondary APS. In secondary APS, you might have to consider that you have to treat the secondary condition as well. For instance, malignancy, for instance, infection, for instance, autoimmune diseases such as lupus. You will have to give an immunosuppressive regimen. I think this is more important about it.
Do you want to take, Dr. Chengappa, do you want to ask some questions?
Yeah, there are a few questions on the investigations to choose from.
Yeah.
So what are the investigations that we have to routinely send or ask for? And the second thing is, should we start vitamin K antagonists before sending the investigations or after?
Yeah, that's what I told you before. You need to have a lab that can cope with if anticoagulation is on board. So you need to find out what in your surroundings is a lab that can deal with probes that are contaminated by vitamin K antagonists and or NOACs, number one. Number two, if you suspect or screen for antiphospholipid antibody syndrome, be prepared to do it the right way, meaning you have the specialized lab and you send in probes for all 3 antibodies, and you make a note that the patient has to be retested 12 weeks or later thereafter. Number 3, if you have the feeling that the patient is a high-risk patient for a recurrent event, even if at that moment you do not know whether it's APS or any other disease that the patient may have, you of course start with a secondary prevention that you deem appropriate in that situation. You just need to cope for this by telling the lab, the specialized lab, listen, this is a blood sample coming from a patient who is treated with warfarin. And then they should know what to do. And the decision to switch your treatment, for instance, if after 3 months the patient comes out as not having a cardioembolic source, not having APS, nor any other condition that warrants anticoagulation, then you switch anticoagulation to platelet inhibition. If in the beginning you don't see a clear indication for oral anticoagulation and you don't have any clinical diagnostic criteria making APS a very likely diagnosis, then I also would primarily start on aspirin and not on warfarin. So if the patient you have is a 55-year-old woman with a history of 3 aborts, she has no living children, she has had 1 venous thrombosis at the age of 30 without having ever smoked or being overweight, and now she has an arterial stroke where you don't have any other idea where it could come from. This is a patient where I would think, maybe she has an APS. The clinical criteria are suggestive. So this is a patient I would start on oral anticoagulation based with VKAs, based on the fact that I have a suspected antiphospholipid antibody syndrome, and would make a mental note to do the tests, to redo the tests. And when the results are there and it is an established APS, then she stays on VKA. And if the tests are negative or 1 antibody with low titers, then I might consider to step back to antiplatelet therapy. Does that answer the question?
Yeah. That just leaves us with one more thing. Your thoughts on seronegative APS?
Sorry?
Seronegative APS, where all these 2 labs are usually negative and the autoantibody levels are negative, but there's a high suspicion.
I didn't really get the question, sorry. Whether I have seen myself an APS?
Which is seronegative.
Can you spell it out? Sorry.
Not positive for any of these antibodies.
If you're positive for any of these?
Not positive.
Not positive.
Okay, if you're negative.
You're negative for all antibodies.
What I would do then? I would give aspirin or clopidogrel, one of both.
Okay.
How frequent would that be? Any idea, Dr. Chengappa? Because I think, is it well described, complete seronegative?
Yeah, it is well described, and the newer antibodies seem to be playing some role in predicting if we can diagnose them, like IgA subtype of anticardiolipin, or could be anti-PSPT, that is phosphatidylserine prothrombin antibodies.
It's established in the diagnostic criteria are only the 3 I have told you with the current diagnostic criteria. The problem is that there is, I guess there might be many antibodies that are associated in this kind of prothrombotic autoimmune disease. And whether they are causative or just diagnostically strong, I think that remains to be seen. I believe that there is an additive and causative component to those because they are known to act at the vascular endothelium. I would address that issue more from a practical reason. We as neurologists don't see these patients in primary prevention. We don't see those with multiple abortions. We don't see those or spontaneous aborts, I should say better. We don't see primarily those who have venous thrombosis or a pulmonary embolism. These are not our patients. So by default, APS patients with a stroke, we see the high risk patients. And I, in that situation, would adhere to the antibodies tested for which we have at least some data. And these are the three that I pointed out.
Yes, thank you. I think you made a very interesting statement on the coagulopathy with the anti-phospholipid antibody in COVID-19. In fact, in our meeting, last meeting, we presented, one of our colleagues actually presented from Sion Hospital, 3 cases of strokes with COVID-19. So that's a very interesting, sort of thing that we need to keep in our mind to test for the anti-phospholipid antibody. I don't know, Dr. Chengappa, any experience on that?
No, sir. No. We luckily our COVID proven cases are low as of now.
Yeah.
Now I hear you. Yes.
Yeah. Can you hear me? Yes, sir. Peter, I was asking Dr. Chengappa if he has any experience with the COVID-19 and the anti-phospholipid antibody. Do you have any experience, Peter, on that?
No, I don't have news there. We have patients, and we have started to anticoagulate all our patients with the standard unfractionated heparin. We have done tests, and we haven't had a positive APS patient among those that were severely ill. But we have only looked in those that were on our ICU and had to be intubated and ventilated. And I guess also that this sometimes is difficult because our patients that were really sick were unanonymously very old and very comorbid. 2 of them with late stage malignancies, and 2 of them over 80, and most of these patients died anyway. And the only other patients we had that were young were 2, young and otherwise healthy. One was 50, one was 58. Both of those survived, and both of those were APS negative.
What about strokes and COVID-19? I mean, have you seen the younger strokes with COVID-19?
No, but I have to tell you honestly, those patients who died didn't get cranial imaging. They were just dead for pulmonary reasons after 1, 2, or 3 weeks of ventilation. And we didn't check for stroke. And in an intubated, ventilated, and nalgosedated patients, a stroke usually doesn't show itself. Yeah. So actually, we don't know. And among those patients who are COVID-19 diseased, but not ICU, not severely diseased, in my hospital, there has not been a single COVID-19 associated stroke yet.
Right. That was interesting that from the Sion Hospital, Dr. Uma presented 3 young patients with stroke and COVID-19 positive. And that was interesting. So I think, Dr. Chengappa, unless you have any more questions from the audience?
Just one more, sir. The duration of treatment. How do we fix the duration of treatment with VKS?
This is also a question where I just can give you my personal opinion because there are no data. It's probably the same as in dissection. In dissection, we don't know how long to treat with antiplatelet or anticoagulation. We just don't know. 1 year, 2 years, forever. And the same is true for APS. On the other hand, I think that the risk for a recurrent vascular event, whether it be venous or arterial or microthrombotic or obstetric, is much, much higher than in dissection. So my advice would be, first of all, you need to nail the diagnosis. You need to be sure clinically and laboratory testing wise that this is an APS. And if it is an APS, there would be no reason for me to go back from oral anticoagulation. I would do it lifelong. There is maybe one exception I could think of. If there was an autoimmune disease that is sufficiently treated and stable under immunosuppressive therapy, and the antibodies, the APS antibodies, all three of them completely vanish, which I've never been seen. And I asked my hematologists, they can't tell me stories about that, they just don't know. But if I saw that, I would consider downgrading from warfarin to lifelong aspirin. But that is just a personal hunch, an opinion. Sorry, I can't give you more.
Yeah, I think all of us are on the same boat with respect to the duration of treatment.
Yeah. So I think I agree with Peter that I would give it lifelong if there's a strong, clinical and lab, sort of match on with the APS syndrome. But I think it's a little debatable. I think we've run out of time, and I think we need to thank Peter for this great talk, and thank you